Right, now I need a We don't need this, do we?
Morning. Yeah, good. Yeah, no, good. Dave, would you mind just giving us a heads up just before you start? Just so we can-
Yeah. All right, now.
No,
Yeah.
no,
Yeah.
one body
In the shots, there's are my boys' cards in there.
Yeah.
Yeah, you've seen
Is that okay?
yeah, no, that's good. I'll put them there, so I'm sure they'll be pleased to see them, you see.
Nice touch.
My little boy asked me, he said, Daddy, are you teaching people again this week? I got off last week to do some teaching. I go, no, Steady, I'm learning this week. I was really confused as how he thought his daddy was like the dude.
Knew everything. But what are you learning, Daddy?
What am I learning?
What could there possibly be for Daddy to learn?
Which school you go to will depend heavily on...
How much Daddy learns. Ben, do you want to have any fiddle with the temperature control? It's a bit hot.
Is this a microphone?
Ah, don't do that. No, don't do that.
Out clubbing in Cork last night, Floyd. I left as late as possible because I figured if I'm in a buffet canteen for any longer than 10 minutes, there's a lot of damage I can do to my waistline. Because I just keep on eating sausages and bacon to whatever it is, eggs, orange juice. Is there a ridiculous amount of sugar in a cup of orange juice?
There is.
Depending which one it is.
Yeah.
Fresh is bad.
I think all the brown ones are pretty good.
So are we missing anybody? Yes.
Chris,
Yes. Where is Chris? I saw him earlier. He's in breakfast.
Yes.
Does everyone sleep well? Good night? Yeah?
Yeah,
Good. The rooms are quite big, and it's nice that you always get a double bed and stuff. The only trouble is the lighting. It's just really... It's all mood lighting in the rooms. It's really gloomy if you're trying to do any work.
The side light's pretty good. On the bed, it's a sitting bed, it's alright. The side light's quite strong.
But the desk is
You need
hopeless.
to get room, next time you come, Dave, you need to get room 315. That's the daddy.
Is it? The,
The big ones again.
It's got a balcony, it's got a living room, it's got a dressing. It's pretty smart. And
the film
dressing
style
room
room.
is actually not. It's very reasonable. It helps if you don't book 2 days before.
Right. That helps.
You get a smaller room.
Right.
Because I think you said there was some preferential rate, so you can access it online. So I thought I would phone them, and I forgot to phone them, and so I only remembered to phone them on Wednesday because there was nothing online. I was like, oh shit.
Yeah, it's been booked up for
I'm
ages.
going to be staying in somewhere else.
Almost.
No, but I block booked a load of rooms, so but you're obviously all right in the end, so it's good. Where's Chris then?
He was at breakfast ages ago.
Yeah, he was. Yeah. Okay. Hi, you all right?
Different times there for the lunches, so I have you down for 10, and then I have you down
Or for the coffee?
1 o'clock for
Yeah, that'd be fine. Just thinking of the morning one. If we make the morning break at say 11,
11, yeah.
and then lunch at 1 o'clock. We'll do that. Thank you. Ah,
Just no. Sorry.
don't worry about it. Don't worry about it. Okay, ready, guys? Okay. Where's Ben gone now? Right, good morning, everybody. Refreshed, ready to go? No? Yeah, good. Now, one thing I want to start with, very briefly, is a topic we started yesterday, which is increasing the response from your website. And what we talked about then was very much structure. So what you should have, where you should put it, that kind of thing. We did a couple of critiques, of course, and that's the first half. The next part of increasing the response is your content, all right? Now, as I say, the mistakes people make really are building brochures, building CVs, and that kind of thing out of their websites, which is not conducive to getting more patients. And your content should be something much different, and that is relating to the patient. And the first mistake that you want to avoid is writing in the third person as you would for an academic paper, all right? The key thing about writing is to write like you speak, all right? Because we don't speak in the way that we write a paper, and it's very, very alien. And it comes across as alien, it doesn't connect with people, and so it's daft. So imagine the patient is sitting in front of you in your office, and you're talking to them about their condition. Try and write in that manner, okay? Very, very simple, I, you, try and avoid we, but it's better than anything else. But I is the way to go, okay? Keep it very, very personal, keep it very, very simple. In terms of the language, it sounds obvious, but people continuously get it wrong. Avoid jargon like the plague. The only exception to that is that there are certain conditions where people know the jargon. So I can think of an example, cataract, for example. They know what a cataract is pretty much. But for the most, and there are a few of those conditions around. So in that case, of course, use it because it shows that you're medically qualified as well, that you know what you're talking about. But other than that, keep it really, really simple. Call it, wear and tear of the joint. Call it, fogging of the lens in the eye. That's a cataract, that kind of thing. So keep it very, very simple in terms of jargon. Get rid of that as much as possible. The next thing is in terms of the structure of your sentences. Keep it really, really simple. Think sun reader, okay, without the boobs and the tits. But other than that, keep it really simple, because the average reading age, depending on which literature you look at, is around about 11. That's the average reading age in the UK. So your content should be intelligible to an 11-year-old.
So you're talking about the website now?
We're talking about everywhere, in fact, but specifically a website. In all your content, this will apply. So think of the structure, avoid the jargon, and think about the structure of your sentences as well as the content. Say content, avoiding jargon. Keep it really simple, yeah. And then when you've gone through it, read it again and make it simpler, because the trouble is we're all geeks and nerds about what we do, yeah. And jargon, of course, it's a throwaway language for communication between professionals. Yeah? So we can speak about complex matters very, very quickly and simply and easily. It's about transmitting information between us, but not to Joe Public. Okay? So that's really, really important. So you've got a page, say, talking about cataracts or prostatic hyperplasia, or wear and tear of the knee joint, whatever it might be. Start from the basics. So what is it? You know, how common is it? Why does it matter? What are the kind of symptoms that this will give you? Why you should seek advice sooner rather than later? Could it be something else? And for most conditions, the first thing people think of is it cancer. As I say, don't over-egg the pudding. Don't mislead people by over-stressing a link that might be there, but answer the question. So it's very unlikely to be cancer, but these things do need to be checked out sooner than later, because whatever the cause, the easier it is to offer a treatment and return of function and blah, blah, blah. But you see what I did there? I screwed it up, return of function, yeah? You don't say return of function to a patient. It's not what you say. But it's how easy it is to fall into that trap. Think of all the questions patients will have asked you about that condition in your clinic. Yeah? All the obvious basic things that they'll be asking you, like do they need to come in and stay overnight? Is there anaesthetic? When can they go back to work? That kind of stuff. Think of the 10, 20 top questions you're always asked. They will seem trivial to you. It will be very hard, in some respects, to think back what kinds of things they're asking you, because you get them all the time. But it's really, really important. Okay, answer those questions. Don't put them as an FAQ. Answer them in your content. So, this is what you can expect when you come into hospital. I will see you personally myself in my clinic. Yeah? We will talk through your problems, what your symptoms are, how long it's been troubling you, and that will give me a very good idea from the start what is happening. We'll arrange a few tests. Usually this involves an X-ray, MRI, whatever it is. Then cover what an MRI is. This is a very simple test that you're in a machine, it's very noisy, you've got headphones on, quickly what it is. We'll get your results after that, and that will guide me as to what is going on and what needs to be done to fix it. Usually it's very simple, it can involve blah, blah, blah. Occasionally an operation. If you do need an operation, I'll go through exactly what is involved with you. You'll see my anaesthetic colleague. So that's it. And then the next thing is, on the day of your operation, if you need an ACL reconstruction, I again will see you personally, explain everything once again, go through the operation with you myself. Yeah? Stress that, because that's what private medicine's about. That's what people are buying. Yeah? You will then see one of my trusted colleagues, either Jim Jones, the anaesthetist, or Julie Smith. Been working with her for many years. She's really, really good. She'll put you at your ease about what to expect, about the anaesthesia or whatever it might be. You'll then be taken into the room and you go to sleep. Next thing you know, you wake up and you'll have a bit of a bandage on. You'll feel a bit fuzzy in the head, but you'll go home later in the day after a cup of tea or coffee, whatever. Do you see how simple it is? Nothing complicated, and answering the questions you always get. The next thing is you should answer the questions that people should ask you about the procedure, but don't. And again, this is slightly more complex than it sounds more complex than it is, because what we're talking about is consent, basically. And that will make it a lot less problematic and traumatic going through the whole consent procedure at later dates. And you're just reinforcing the issues that you talk about. Okay? Again, make sure you don't minimise serious risks. In the same way as you don't want to maximise the threat of a cancer or something to get them in. You don't want to minimise the risk, so they say they'll do it. But you wouldn't anyway, but it's just traps that it's easy to sort of be seen to fall into. Did you?
There's been a lot of talk at work recently about options of doing nothing. And so you have to be very clear in all your letters. We discuss options of conservative management. I just wonder if there's a place for that here in terms of saying, if you ever have to defend yourself, well, say, here's it, I've already got all this and I relay this again in clinic.
Yeah, I wouldn't worry too much about defence, except, as I say, to be able to defend everything you've got there. So you're not claiming something that isn't correct and so on. But it's always good to put the options there so that people, so for example, people are frightened of operations. Of course. The vast majority of people, anyone who's sensible does not want an operation. And often, even with degenerative joint disease, whatever, they don't need an operation. So say, we will go through and find out exactly what's happening. often, there will be various options of treatment. You may need an operation, you may not, you may be able to do it, whatever. But just, answer the questions you always get asked. The key thing, what you're trying to encourage people to do is to come in. You're not trying to make a diagnosis. And it's very easy to fall into the trap of trying to make a diagnosis in your content online, to try and filter people. And you can't do it. So that's your content about the condition. The next thing you want to do on the page is to give them examples, case studies of patients you've treated. Now, these are not case studies as you and I understand them, okay? We're not talking about rare and one. As I said, we're all geeks and nerds, remember that. We are fascinated by our subject and by our patients and what can go wrong with them. So you and I are fascinated about things such as the 35-year-old man who's got an intractable cough, who turns out to have a mediastinal yolk sac tumour. Yeah, that floats our boat, but it's totally irrelevant to Julie and Jim patient. So the case studies I'm talking about are the typical presentation. So your chap with heart failure, for example, he's got worsening shortness of breath, exercise tolerance, blah blah blah. You see again, exercise tolerance. We talk about that. Patients don't. So, they can walk less far, they're this, they're that, they're feeling like an old man, they're not sleeping well at night, they wake up coughing and spluttering, that, whatever it is, then he came in to see you, you diagnosed that he had heart failure, and you gave him some medication, and he felt much better, he felt like a new man, which is literally how they feel, of course, when you have heart failure treated. And they can't believe how ill they've felt over the last 6 months, year, whatever it is. It's an astonishing change, isn't it?
It is.
So get those case studies out there. Yeah. So that's the kind of case study I'm talking about. Very, very boring and ordinary. To give you an example from general surgery, the bloke who presents with a hernia, there's sort of two types. So you may need more than one case study. So there's sort of two broad types for presentation with a hernia. One is you've got a fairly strapping bloke, maybe has a manual job, well covered if not a bit chubby. He's got worsening right-sided groin pain. It's troubling him more and more at work. He hasn't really felt a lump, but he's been to see his GP who has either diagnosed a hernia or can't feel anything and isn't sure. He sends the patient to you. You examine him. You can either make a diagnosis of a hernia right away or you do appropriate imaging and make the diagnosis. You then proceed to either an open or a laparoscopic repair as appropriate. He's fixed, he goes home the same day, he's back at work within 2 weeks and is feeling completely fine. This is all, this is what we see all the time. This is the progress of these patients. It's very, very simple. The other typical case study, if you like, is the old boy. He's often either he's either often from abroad. He's been living here for many, many years, but he's got some sort of sheltered, very sheltered life. He's got some good family around him who've been nagging him to see a doctor for many years because he's got a huge lump in his groin. He's got a massive inguinoscrotal hernia. He's got baggy trousers with the bulge that you can see there. He's a bit disheveled. He's a bit unshaven, a little bit stooped. He's finally been brought in to see because he's been badgered by his family. You've examined him. He's got a massive inguinoscrotal hernia. You bring him into hospital. You sort it out. He's in for a few days. He gets better. He's still a bit, grumpy and miserable because that's his nature, afterwards. But he's got a bit of a smile on his face. His family are delighted. Thank you very much. Discharged. These are the kind of case studies we're talking about. And if there's more than one kind of case study per symptom or condition or diagnosis, so sometimes there's symptoms, sometimes diagnosis, yeah? Because the patient won't necessarily know a diagnosis. But if there's a different scenario, cover both of them. So in your case, you've got Doris, who's, ambling around, she's ancient, she's elderly, she's at home, she's sleeping in a chair, she's been doing that for many, many, months or over a year. She's got peripheral pitting edema, etc., etc., etc. She's refused to see a doctor. She's finally either seen a GP and sent to you, or her daughter has brought her in, and you make a vast difference to her life and quality of life. That's the sort of two presentations, isn't it?
Can I see, is the idea that there is a sort of tab for case studies that patients click on and they CVs or?
No, it's one long page. Do not worry about having one. You want to start talking about that condition and keep going down the page talking about the condition. You don't
On
want
your front page, on the home page.
No, so we talked about tabs, didn't we? So at the top you've got home, you've got, so for general surgery you've got home, you've got abdominal pain, you've got change in bowel habit, again slipping into the lingo, yeah? Or you've got rectal bleeding, whatever it might be. You've got lumping groin, and on the lumping groin page, for example, we've gone through the whole thing about what it could be,
I see.
and you just keep
Okay.
going down and down.
In the same way that you have your 3 buttons, and that could then also link to those.
Yes.
Yeah.
Yeah, but on that one page you've got everything
Yeah,
at once about hernias, cataracts, whatever it might be.
Yeah.
Yeah.
I see.
What sort of font size should we use?
It's all about legibility. So I think you need something like between 60 and 80 characters across the page. It's quite big.
16 to 18.
60 to 80.
And also you have to, you've got to be careful. Remember you were saying the colours
Yep.
and not having background pictures to
Yep.
distract.
So again, this is going back to structure, but yes, you want a white page, and that looks clean and professional, which is good, or very, very, very pale grey if you must, and you want jet black font on top of that, all right? There's lots of studies about which font is best. Keep it simple, don't worry about it. Use Arial or use Times, don't worry about it. These do make a difference, actually. They do make a material difference, but what we're doing is trying to do the big things that will make the biggest difference, and we can tweak little things afterwards. All right. So you've got yep.
So with the case studies, do we mention names, first names or not?
No, I would just make up a name, or if you've got a typical patient in mind about all these things, so just
Yeah.
say Edith.
Can you ask someone to do it? So, for example, I did an ACL reconstruction of, it turned out he's a mate of my wife's, a husband of my wife's friend, and he's done well, etc. And he's just, he said, well, intelligent guy, but he could probably write a really nice précis of what happened. I was surfing, I slipped, my knees swelled up, I wasn't quite sure what was going on, it's giving way, I meant to use the Pablo or
Yeah, you can.
whatever.
Of course you can.
Got a scan, told me I had an ACL rupture, went through the options, we did my operation, and now I'm back surfing.
Yeah.
Something like that.
And that's a really good idea, because it's like this, Jim Jones's story in his own words. The only trouble with that is that they will often not cover stuff that you should cover, such as saying, for most of the cases, these things settle down and you don't need an operation or whatever.
Yeah.
But as a case study, it's a great one to have in there. So I'd put that on at the end for sure.
So 60 to 80 characters, that means like 12, 14 font, isn't it? Really?
Yeah, don't worry about details. If it's hard to read, and it depends, well, I mean, eye surgery, these guys, often it's the relative that's bringing them in, but still, you're going to think of a bigger font still, yeah? And you're going to do even more to make it more legible. Don't worry, yeah? If you're looking at it and it's like tons and tons of text and it's small, then you'll know that, yeah? But that's a very easy thing to change, yeah? Get the content, get the stuff down, then these little tweaks are simple.
And obviously you're going to have a look at a few of your colleagues and some other people who got good websites, you're going to get some ideas.
How do you know they're good?
You don't.
Right. All you know is they look pretty and you like them. But are they generating patients? I've never met a consultant who said, yeah, website's doing well, getting plenty in. They've never proffered that information. And when I've asked, they all look a bit sheepish and, well, I don't really know, maybe one or two hardly at all. A, they don't track it, but B, they are aware, and they're often aware in the same way as you guys are aware. It's like, well, I don't really get any in. And you're a bit embarrassed as well to admit it. And besides, they won't tell you anything anyway, and you can't trust whatever they do say to you because of the rivalry between consultants. It's just the nature of it. So what you're talking about is whether you like the look of it. By all means, get a website you like the look of, but then see and get it designed that way, sure, but according to principles of best practice that we talked about yesterday, but then see how it responds and change accordingly.
What you just told us to do, we're only doing that for our 5 common conditions. We're
Correct.
not doing that for 100 conditions.
Exactly. Yeah. Because there's another reason. A, it's pointless, and B, you're talking about pancreatic insulinomas, yeah? I mean, what's the incidence of that? 5 in a million, something like that? One
You're not
in
trying to
5
do it
million?
online
The
exactly.
point is that somebody will occasionally turn up with that, but there's no point spending all the time talking about this. It's so unlikely that they will and end up with you. It's a whole heap of work. That was the point of going through the Lowell's 3-list analysis and working out the incidence, the top 80-90%, the top conditions that provide 80 to 90% of your work. Yeah? Plus the couple of rare ones, or the uncommon ones, that if somebody does present with, are very, very good for you. Okay? That's the point of that. Because you want the biggest bang for your buck, the biggest results with, no one in this room is lazy, but you know, there's something that's creating too much work and unnecessary work, isn't there? Yeah? Further down the page, testimonials. Ideally, you would group the testimonials, so you fixed Doris's cataracts, and on the cataract page, you've got loads of testimonials at the bottom there, or a slide of them going past, that's fine. From patients who've had cataract treatment, then glaucoma and all the rest of it. If you don't have enough, don't worry. Get them there, and that's fine.
Can you make them up?
Make up testimonials?
Yeah.
No, absolutely not. Absolutely not. Every single testimony, please do not make this up. Yeah. A, it's unethical and misleading and wrong, and B, it's totally unnecessary. Like I say, we've all got drawers stuffed with, you know, letters and cards from people saying how great we are. Use them. You don't have permission to use them and give people, you know, confidentiality is an issue, so use them blind. You know, JS, the correct initials, Essex or Chipping Sodbury or whatever it is. Yeah, you don't need to make this up, and please don't. You must not.
So just to summarise, so for each condition or symptom, whatever it is, so it's just a paragraph of text with the what is it, how common, does it matter, etc.
It's as
Just
much
cover those
text as
questions
necessary.
in there. Then the questions that they haven't answered but they should. Then some case studies and then testimonials, and that's it for each
Yeah.
thing. Yeah.
Yeah. Put some pictures in, anything to illustrate a point, either drawings or photographs. Remember what we said yesterday about scary pictures, about pointless pictures like an arthroscopy. Yeah? If you've seen an arthroscopy on YouTube or anything, it's hard to see what's going on. You know, you really need to be there doing it. Then it's easier. Yeah? Jim or Julie Jones has no clue, and it's pointless. Yeah? So think carefully about what you're putting there and how you're trying to illustrate the point. It all sounds complicated, but it's really not. What we're talking about is a glorified patient information leaflet. This is the stuff you tell patients with a given condition all the time.
Yeah.
So all I'm saying is put that out there on the page and make sure you write it in a way that, like you speak. Keep it simple. KISS, yeah? Just like when you're talking to a patient, because otherwise they won't get it. Make sure that you've got how to contact you all the way, that's always visible. But that's the key thing about the content, so the studies, testimonials, and so on. Any questions on that?
Just one might sound a bit odd, but normally when I write things, instead of writing in long sentences going around, I write quite short sentences with new lines. So I do that with all my emails. I'll write little statements, and so it's easy to read.
Yep.
Instead of doing it like a newspaper article, can you do that on the website?
You write it as you want. Yeah, the key thing is the idea is to convey information. So do that to the best of your ability. You're all very, very good at communicating information to your patients. The trouble is when you start putting pen to paper or finger to keyboard, you have a brain fart. Because like all of us, we have been trained to, with our research and with our, MDs, PhDs and all the rest of it, that is how you write. But that is not how anybody writes or communicates in the real world, is it? It's very, very strange. So don't be strange under those circumstances, because you're going to alienate people. You're going to read, what the heck's this? And they'll go off. Yeah.
One of the techniques that I think was really useful is you can actually just record it on your phone. You just speak into the phone and then get someone to transcribe it, or you can transcribe it.
Oh, right. So you say it as you speak?
Yeah. It's a good start. It gives you.
Yep. That's absolutely right. That works. The other thing is that when you're doing this, you'll find you've got a massive load of content. You'll think, why am I talking about all this basic stuff, is the first thing. Next thing you'll think, you've got a massive load of content, and now you've got a massive long page. Do not worry about a massive long page. Yeah? Put down all the information. Some people only want to read a little bit, and then they'll pick up the phone, or leave. Yeah? But some people want to read a little bit, and then they'll pick up the phone. Others will want much more information, will read far down until they get the information they want, and then pick up the phone. So this way, you cater for the people who need a little bit of information, as well as those need a lot. All right? When they're fed up, they will go. The problem is if you just put a little bit, is first off, you're not communicating half the stuff you should. And secondly, people read a bit and then they don't get what they want and they leave. Yeah? People will, and you can have a massive long page, you scroll and scroll and scroll. Don't worry about it. All right? The crime is not the length of the page. The crime is the poor communication and making it illegible and jargon heavy and talking as if you're talking to like a robot or talking to a colleague rather than talking to a human being. All right? Imagine Doris is sat there in front of you with her daughter and you're trying to explain what you're going to do. Now, an A-level strategy from this, by the way, I don't think I told you about this, but I alluded to it, is we talked about the problem of having NHS patients who are either insured or who have who are the willingness and ability to pay. We've all seen many, many times in our clinics, and the question is, what can we do ethically to encourage those patients to be seen privately? What I would suggest you do is, because you've got all the content on your website in this way, it's basically a patient information leaflet. When you see Mrs. Jones or Jim Smith in the clinic, say, look, go and have a look at my website, all the stuff we've just talked about, and here's your patient